Thank you very much. So for the next 10 minutes, we're going to talk about very basics about TAVR. I know TAVR is an infancy in Bangladesh, and Dr. Pradeep and his team has done a few cases. Dr. Momin has done a few cases. That reminds me of our beginning days when even in my previous program, I had to go to Germany to train with Dr. Marcus Kassel to get my numbers to start the program. But I think it's the future, and so we're going to talk some basics, and after that, Professor Chaudhary will talk about how to start a TAVR program. So we are going to talk pretty much about the indications of TAVR or TAVI, the complications of TAVI, and we're going to talk about is TAVI the right procedure for your patient, and how we deal with the heart team approach to decide what's going to be the best for your patient. I have no disclosures. So the first question is, you have a 82-year-old active male with history of hypertension and hyperlipidemia who presents with shortness of breath and severe aortic stenosis. So what would be the right approach? Would it be TAVR, SAVR, or open heart surgery, or just medical therapy? Anyone from the audience? Anybody? The junior cardiologists? Any volunteer? What do you think for this particular patient? We will come back to this question, but let's see, the second one. A 66-year-old male with history of diabetes, previous bypass, COPD, hypertension, presents with symptomatic severe aortic stenosis. And what will you refer for? Again, TAVR, SAVR, medical therapy, or Ross procedure?
Nasser, first was asymptomatic. I am Dr. Professor Mustajaman here. Right.
The symptomatic. The first patient was symptomatic.
Symptomatic.
Yes. So.
So in this patient, with medical therapy patient is symptomatic, he needs some intervention. Definitively, I think first one is the best choice.
The TAVR, yes. So we will come back to this.
Same is for the first patient also.
Yeah. So you're absolutely right, but we will come back to the guidelines, how the guidelines have evolved and has become age-based now for indications of TAVR. So the third question is very similar, the age, but this is a 62-year-old patient with bicuspid aortic valve, hypertension, hyperlipidemia, comes with shortness of breath with exertion and mean gradient of 42 millimeter mercury on echo. So will you refer this patient for TAVR, SAVR, or follow-up in 6 months?
Third option, follow-up with 6 months.
So that's a tricky one, because the patient has, although we said mild exertional dyspnea, but does have some symptom. So this is something also we see. Sometimes the patients downplay their symptom, but they have started the active process of aortic stenosis. So as we know, aortic stenosis it progresses in many cases indolently. The patient doesn't even realize. But when you have severe aortic stenosis, the prognosis becomes very poor. And you develop the symptoms of angina, shortness of breath, and heart failure. And when that happens, the survival, I'm not going to go into the question. This was like in 2 years, what is the survival rate? So in 2 years, the survival is only 50%. And in 5 years, the survival is only 20%. So majority of this patient, if left untreated, will die. So that comes the importance of treating the severe aortic stenosis. And the problem was, we know that these are the basic numbers for the junior fellows, but you all know this. When the mean gradient is more than 40, we call it severe aortic stenosis. When the AVV max or the velocity is more than 4 meters per second, or the aortic valve area is less than 1, we call this severe aortic stenosis. So you have these echo features and the patient has symptom of shortness of breath or tiredness with activity, this patient is in trouble. So the surgery was the time-honored custom that evolved over the past 50 years. So we know surgery works. But the problem is, in many patients, just like as you mentioned, the surgeons will turn the patient down. They will not want to do the surgery. And this patient, we just try to treat them medically and they eventually just die or develop heart failure. So the first concept was why can we not just use balloon valvuloplasty as we do in mitral valvuloplasty? Just put a balloon, open the valve. But the problem is, more than 50% case, you have restenosis, and there could be a rupture and high complication rate, and these patients eventually will not survive. So it is not as successful as mitral valvuloplasty. So this is a whole different ballgame for aortic valvuloplasty. So the first year, any idea when the first TAVR was performed? 2002, 2004, 2006, or 2008?
2002.
Excellent. So in 2002, Alain Cribier in France did the first TAVR, and in a very sick 57-year-old patient, and that started the journey. And like I was mentioning, it started in Europe first and then came to USA. And in 2011, it got the first approval. But since then, it took really a course. You can see in 2016 in USA, the number of TAVR went up and the surgical volume came down. So it crossed. And it's still going up. And worldwide, we are seeing the trend. So just like I said, it's just a matter of time, even in Bangladesh, we will see the rise of TAVR. So I'm not going to go into the details for the sake of time. But the partner trial was the first trial that started with the high-risk patients, and this was a non-inferiority trial. So the first partner trial showed that TAVR was non-inferior to SAVR open-heart surgery. Then come the partner 2 trial, which was in the intermediate risk group of patients, also showed good results, non-inferior. And finally came the partner 3 trial, which was done with the low-risk patient that showed actually benefit over SAVR of TAVR. So what happened was, with time, the complication rate decreased, the devices got better, and the operators got more experienced. So we got better results with the recent partner trials. So that really changed the whole scenario, and now this is essentially showing all the meta-analysis. And so the partner trial was done with the balloon expandable valve, and we also have a self-expandable valve, which is the core valve, also showed very good results. So based on this, now the new guidelines, just we were talking, is age-based. So if someone is more than 80 years old, we always prefer TAVR. If someone is less than 65, still the open heart is preferable, considering everything else. If someone is between 65 to 80, it's the shared decision. We talk to the patient, decide what's going to be the best interest for the patient, and take the patient's opinion and then decide. So these are the valve types, but the most used are the balloon expandable, the Sapien valve, as you can see in the picture, and then the self-expandable, the core valves by Medtronic. So which valve is better? There is no really large head-to-head trial for this. Sapien valve is easier to put in. We use it mostly in most centers in USA. We choose the self-expandable valve if you have a narrow annulus or you have a large chunk of calcium, because in those cases, the balloon expandable can cause annular rupture. So the transfemoral is still the preferable, and most studies have shown that is the safest way. If that is a problem, we can choose the direct aortic transapical. Transcarotid is also becoming popular these days. We are getting more and more minimalistic strategy, so we are trying to move away from general anesthesia. We're just doing it with conscious sedation, and just no TE, even just a transthoracic echo. And we are sending the patient home the next day. Just observe them overnight. We get them up and make them walk the same day and send them home the next day. So let's talk about a little bit of the complications. And we know there are a lot of acute complications, the vascular complication, the rupture, but the problem of long-term complication is multiple. And that's why for younger patients, we still do not know the long-term data. So the main problem is you can have a perivalvular leak, and that has increased mortality rate. Even now, there's 8 to 10% need of a pacemaker, which for a young patient may not be the ideal thing. If you do not have transfemoral access, the other alternative access may not have as good results, and the annular calcium can rupture. PCI after a TAVR, especially after self-expanding, can be a challenge, especially a primary PCI, the middle of the night could be a challenge. So if it's a young patient, those are the things we have to keep in mind. Also, the durability of the stent comes into question. So that's why we get together. The surgeon is always involved. In USA, a surgeon is always scrubbed with us, and we also involve the surgeons in decision making. This is called the heart team approach. And we get a coronary angiogram, TAVR CT, carotid duplex. With all this information, we sit down and decide if TAVR or SAVR is going to be better for this patient, and if it's a TAVR, which valve we're going to use. We usually put them on aspirin lifelong and clopidogrel 75 milligram for 3 to 6 months. We also can do a valve-in, valve TAVR if that's needed. And even bicuspids are also acceptable. We do a lot of bicuspid valves, TAVRs. So also, if they have a associated mitral regurgitation or low EF, we proceed because in many cases the EF improves and the mitral regurgitation also improves. So I guess the take-home message is TAVR is here to stay, and it's an evolving technology. And new guidelines, just we talked about, are age-based, and it is a multidisciplinary approach. You have to involve the surgeons as well, and it's a shared decision-making where the patient also has to know what's going on, and early referral is very important. Thank you.